with a break. How about some questions that must have arisen as you listened to this presentation from HCA?
So I see that Rhonda had a question, and then actually I have a couple questions as well.
Well, can we go girls before boys, then Wes, and we'll have Rhonda. So Rhonda, why don't you just instead of me reading the question, why don't you just paraphrase or actually restate the question for the two?
I would be happy to. Hi, Michael. So I didn't realize I was the last question before your presentation, but you know, we have participated in lots of demos, and the big challenge is, you sort of alluded to and Wes did earlier, is at this point, none of the CIEs have a feature where they will integrate with our EHRs. And we are so inundated with registries as they exist that I can't imagine, and we've all, and many of us have already invested in being able to capture our social determinants, and we have to report them. The community health centers are required to report them already in our annual reports. In your development, will you be requiring the CIEs to be able to integrate with things like our EHR system, the homeless management information systems, you know, the health home registries, all these other things, registries that we're already involved with? Is that part of your expectation and development?
Yeah. Hey, Rhonda. Hello. Nice to see you. And let me thank you for asking a question that's out of my league to start with. But I'm going to attempt to provide an answer, you know, with the caveat that I'm going to get back to Carol and Wes as things change. We talk extensively with our chief technology officer, Jerry Bridger, and of course, our chief data officer, Vishal Chowdhury, about these issues. And Rhonda, I'm going to attempt to paraphrase what they are attempting to teach me about this. And first of all, is that we do recognize that there are EHRs that have been implemented everywhere. And it will be a challenge to figure out how the CIE connects with those. From a technology standpoint, it's interesting when I listen to Jerry and Vishal, because they talk about the EHRs somewhat separately than they consider a community information exchange. But they do recognize the value in trying to make all this work together. And of course, through One Health Port, we have even started implementing an EHR. So we have some investment there from the Healthcare Authority perspective. We also recognize the potential to mess this up a little bit, which, you know, would be duplicating efforts and making people do things twice, and we want to avoid that as we go forward. So what we are likely to do, and again, let me just fill this with caveats, because as we go forward, if things change, we'll be sure to communicate with that with all the ACHs. But what we are likely to do on CIE is initially work with the community-based organizations and do the best we can with those non-clinical community-based organizations to knit those efforts together. And that goes back to the circle diagram that Chase had. We are pretty much starting up there at 12 o'clock and then going to the right, 1 o'clock, 2 o'clock, 3 o'clock. And so when you see resource directory, closed loop referrals, we're attempting, we believe that we'll probably start with trying to knit together the community-based organizations. And then as we go further, work on thank you, Chase, work on the clinical community linkages. So again, as we dive into this for real, if we get funding and truly purchase a CIE, then, you know, our ears will be in the ground. We'll listen to you, we'll listen to the ACHs, but, you know, going into it, I want to let you know that's our impression right now in how we can be successful. And again, we have a lot of conversations with the communities that have to occur around the challenges that you have right now, and of course with governance. So with caveats, let me say that could change as we listen, but that's our approach at the moment. And if I could, Chase, anything that you would add to that? You've been in on all the internal discussions.
No, Michael, I'm glad you brought up the point around, we're aware of the potential for duplication. And I was going to say the same thing until you said it around, the goal would be to leverage what already exists and not require any additional kind of overlapping systems. But yeah, I think that all the caveats around work to do to get that and to realize that.
Rhonda, any quick reply?
No, I know it's a lofty goal, but just as an example, what I would say is right now on any given day, we have certain high needs clients that we're entering information on in 4 different registries. Our next gen EHR, the health home registry, if they're a health home client, a homeless management information system, and the SAMHSA SPARS registry if they're chemically dependent. That could be for one visit, 4 different registries. So, and that's not unusual for us. So I just, I understand it's a complicated process, but if we're going to have buy-in at a community level, we have to do it if we're going to have, if for an organization, a healthcare organization, to find value in a community information registry. It's just not going to work until we get there. Thank you.
Yeah, thanks, Rhonda. I'll just say we meet weekly on this issue, and I'm going to bring this up at the next meeting. So thank you.
Wes, did you have a quick comment? We've got just a few minutes left in our slot for Michael and Chase.
Yeah, so first of all, I appreciate Rhonda's comments, and it's a belief that we had been incorporating into our work in terms of trying to integrate this work to reduce provider work. My question is, and I'm hopeful by what Michael and Chase has just told us, my question relates to timing here. We're trying to get this going as quickly as possible. It would be great if HCA could come up with a vendor that serves, that's in alignment with what our stakeholders and partners tell us their needs are for such a system. But, I don't think we can wait forever. And the idea of creating standards certainly, puts an additional filter on vendor selection. But again, I understand the needs for that and around governance. So I'm wondering if either of you could speak to the issue of timing and when some of these things might get accomplished in terms of vendor selector, creating standards, et cetera. Thanks.
Yeah, Chase, or Wes, thank you. The when is always so difficult to predict, especially when we all wish it had been months ago. Probably the best I can tell you, Wes, is we are going to make an attempt, we being Healthcare Authority, to find ARPA money that fits our definition of what we want to do, so that we are going into the right American Rescue Plan Act bucket of money, and then make our case. And then we still have to make our case to our authorizing environment, which I know you and Carol recognize as the legislature and Office of Financial Management. It's unfortunately difficult for me to say whether I think the case we're making is good, but it's difficult for me to say whether that case can be accepted at this point. And so until we have true funding to launch this, it is just so difficult to say that when this might happen. And then, of course, when it happens, we have talked internally at the Healthcare Authority about how we're going to mobilize the project team. So at least we have at least some sense of how we want to get started. And I think at this point, your question is the one that's on everybody's minds. And the best I can do is to stay in touch with you and Carol and the other 8 ACHs. And I would also say that I don't want to discourage anybody from making local investments. I really believe that leave the challenge to us to figure out how to leverage and how to come up with the linkages. Other ACHs have been investing for years, and we don't discourage that. And I know that they know best how to serve their local areas. I would just say that we are the ones at the Healthcare Authority that have to deal with the timing and getting the funding. That's our job. And so by all means, leave the challenges of linkages and governance and listening hard to you once the point comes, and please don't slow down your investments.
Okay, thank you, Michael. Any other questions?
I just want to say, make sure you check the chat, please. I put the link to the survey in there. And again, not to be a broken record, if you could please fill it out during the break. It should take no more than just a few minutes. Thanks.
Right. Before we go to that though, Wes, I just wanted to see whether there are more questions for Michael or Chase from the 60 odd people who are on the call. Surely some of you have had some experience with CIEs, and besides Rhonda, or maybe Rhonda, you're the only one in the 9 counties who's been looking at demos. Has anybody else been looking at demos besides Yakima?
Patrick, I know that Penny Bell is on this call, and I know that they're using NowPow, and wondered, Penny, would you be able to, or would you be willing? I'm putting you on the spot to kind of describe your experience with using NowPow.
Penny, are you there?
She might have.
I think she's on another call, but our experience with NowPow has been pretty good. I would say the only issue we're having is just getting, other partners in the community to kind of work with us within NowPow together. And that's been the biggest issue. But aside from that, it's been really awesome. And you can track how many different types of referrals were sent out to which location for what identified needs. And you can track the needs that, these patients, say they're having. And it's been a great tool.
In Victoria, I would say that that's a similar comment that I've heard even just from the Unitas group. I know Healthier Here is going down that track, and that's been the challenge. And that's what they say is the challenge, is getting people to refer and to use the system.
Right.
And Victoria, just for everybody's information, can you tell us again where you're located and what group you're with?
Yeah, I'm Victoria Bryan, and I'm with Ideal Option, where we provide the medication-assisted treatment services, and Ideal Balance is our sister company co-located with us that provides the behavioral health services.
Okay, very good. Anybody else would like to share an experience with Michael or Chase to give them a little bit more of an information bank as they go ahead and deliberate over what they might provide then to not just our ACH, but to the entire state. This might be our one chance, other than just private conversations that you might have with the two of them. Quick comments. Anybody else from the Greater Columbia would like to offer a comment? Sam, Diane? Okay. Well, Chase, Michael, thanks for tuning in. We are going to take a break now, and but I was wondering whether, and I'm sorry, I know I'm not getting this pronunciation right, but is it Damia or Damia?
It's Damia. Thank you.
Damia, sorry. Could you bring up that, just show people what the questionnaire looks like for those who haven't done it, or is that not possible?
I'm going to click on the link here.
Yeah, just a link to SurveyMonkey. We really appreciate your feedback on this, like Wes was saying, and ultimately this kind of information will not only inform the ACH, but will inform the HCA folks who are charged with developing CIE. So.
And Michael and Chase, we're happy to make the results from this survey available to you.
Thank you so much. And I see that Penny Bell was attempting to speak, but couldn't get through. So Wes, if there's any questions, we'd be glad to respond to them or any comments that she has.
Okay, thank you. Thank you, Michael. So here's the quick survey. You just want to scroll down it. Basically geography, where you're employed, what kind of a perspective do you have on this? A ranking on a 5-point scale about how important this is for your organization, and then some about features, which we think is, hopefully you'll find that very relevant. And then if we miss something about features, please just type that in, and then any other general thoughts. So it should take you no more than 5 minutes, but in the interest of giving everybody a decent coffee break, we've extended our usual 10-minute break to 15 minutes because we want to allow you to do both. And with that, we're going to take a quick break. What do we have here? 10:16. We will reconvene at 10:30. So we're just I'll push back the agenda just about 5 minutes, but not by too much. So enjoy your break, and please give that survey your best shot. Till 10:30. See you then.
Thank you.
Hello, everyone. This is Patrick Jones, your fearless facilitator, and we are scheduled to reconvene in 2 minutes. So hope you're getting your coffee fix behind you, whatever break you needed otherwise. Get your dose of vitamin C outside and put our heads together here and huddle for another hour or so, or perhaps 45 minutes, so we can learn together. That's what these sessions are all about. A leadership council or learning collaborative. So 2 minutes or 1 minute and we'll get started here. Okay, well, let's get going, folks. I see that we have cameras working for 2 Jody Castles. I know there can't be 2 Jody Castles. One must be Dan, and Dan, I hope I don't butcher your name too much, but Dan Ulatowski.
Yeah, that'll work.
That works, okay. And Jody Castle, both welcome. You are with sister organization here, Elevate Health, and we're all ears to hear of your experience with the vendor that you have chosen. So at this point, the floor is yours. And I assume that, is it, Demi, are you going to be running the PowerPoint slides for them, or are they going to do it themselves?
I can run it.
Thanks, Mia. Appreciate that.
Jody?
That's fine.
All
as long
right.
as it's up there, we'll roll with it. So thank you so much for that. Fantastic. Well, thank you, everyone. Thank you for inviting Elevate Health to come and join you in your learning session. So we're privileged to be here. My name is Jody Castle, and I'm the Chief Operating Officer for Elevate Health here in Pierce County. And so we have been asked to come and share with you today our experience in terms of our CIE work and our builds with our platform, our chosen platform, which has been Innovator. And so I am going to brief you. If you don't mind advancing the slide to me, I would appreciate it, just so we get to the agenda slide here. So we're going to go ahead and go over the Elevate Health business model, so you just have an idea of how we have incorporated data into our business model, and that will better inform you as we talk about our build efforts and our in-process integration efforts. So we'll talk a little bit as well about the Innovator product, and then considerations and learnings that we have gleaned along the way. So again, thank you for having us here. And thank you, Demia, so much. We're trying really hard to start incorporating our core values into all of our slides. So I just wanted to touch on this, that these are team developed, and that our core values are community, empowerment, equity, inclusion, integrity, innovation, and reverence. And I just think it's really important to call out because we hope as we talk that you will see all of these things in reference to our business model and work. So thank you, Demia. Next slide, please. So right now we're going to talk a little bit just about our functional business model and how we have incorporated our data initiatives into the business that we have launched with Elevate Health, and what we're looking to do kind of in the future as we progress even past the waiver. Thank you. So here you'll see a slide, and I know this is a busy slide. We have a few busy slides, so I apologize, but they're the easiest way to kind of map out our strategies at a very high level. And so here you'll see this is our basically our cross-sector integrated strategy, and this is actually drafted off the Colorado Opportunity Life Stage Model. And so in looking at this, we really are looking at 3 kind of umbrella groupings in terms of our service line, which are innovation, strategic improvement, and data analytics. And then we have our care continuum network, which is very much a core of what we do. And then we also have our One Pierce Community Resiliency Fund, so our capital stack investments that help support our work collaboratively across the community and across sectors. And so here, this is all undergirded kind of by our public-private partnerships, policy, our value-based contracting, and workforce development. And then I know here you will see some very familiar, the core transformation areas and some additional transformational areas that we have chosen. And so I just wanted to map out at a very high level for you, just kind of our business strategy. Thank you, Dania. And here, this is a little bit simpler slide of how we're looking at data. We look at this kind of like a puzzle. So we have an investment arm, we have an innovations arm, we have our partnerships that are very key to all of this, of course. And then we have data and how we use data. And at the heart of this, we have our care continuum network, because our true goal is to keep the patient and community member at the center of what we do. And so this is always kind of an anchor in our conversations about ensuring that when we're looking at our strategies, that we have an actual human being in the center of this, right? And that we are trying to coordinate care for people in our most vulnerable populations. And we're using strategies to do that, that kind of surround that. And data is one of those primary strategies. Next slide, please. And so in terms of the actual data strategies, we kind of drill down a little bit. Here's what we're looking at in terms of how we're working to incorporate data to serve not only the care continuum network, but the community as a whole. And so what we're really hoping to do is try to have plugins right into our Innovator platform from all these different sectors of healthcare, so that at any point of service, somebody can come in and take a look at a record that really tells them a fuller picture about the patient. And I know that's what we're all trying to achieve with a CIE, but we've kind of mapped this out. So we would really like to incorporate, you know, forensic information, educational information, housing, public health data, healthcare, but claims data, etc. And we would really like to use that in a more collective way in terms of strategy. Because at this point with our data silos, we are all, none of us are speaking the same language in terms of where we're going. We have different alignment, we have different outcome measures, we have different models, and then our data is siloed on top of it. And so really we have no contiguity in caring for patients in our communities at all. And so this is just a really high level kind of visual of our strategy and how we want to bring that into the circle. And we want to really use that to drive community care. All of us have different pieces at this point of the picture of any given person in our community. And we really want to bring that together into a fuller picture. Next slide, please. And so now I'm going to turn this over to Dan to talk a little bit more about Innovator and their unified data platform just as a product. And then we'll talk a little bit about what we've done with Innovator to date. So we've been with Innovator a little over a year. So we launched at the beginning of last year. And so we'll give you a perspective of some of what we've built to date and some of where we're going, and then take a look at what we've learned along the way. So Dan, I'm going to turn this over to you to talk a little bit about the platform.
Yeah, thanks, Jody. Thanks, everybody. Just in quick intros here. I'm the interim CIO at Elevate Health. And so my background is with healthcare solutions, environments, data management, all the boring stuff behind the scenes. And prior to that, worked a lot with more clinical research. So I was an epidemiologist by trade when I first started out my career. And so, you know, in working with some of these care coordination systems, they've certainly advanced over the past several years. Some of these systems function very effectively in their current environments, just depending upon what you're trying to do with them. And so it's really important to understand what sort of scope and delivery you're trying to approach. And I think Elevate Health has a very broad scope in terms of what we're looking to achieve, not only for the ACH, but for the community. So it's not going to be an apples to apples comparison to any of the conversations here, but we'll walk through kind of the evaluation. And Demia, if you can advance the slide here. So this is really the visual that talks about the different applications that Innovaccer brings to the table. And I think, primarily if we start on the top and take a look at InCare, it's really their application that supports a lot of the interactions between our care coordinators and our clients. And so we have developed a number of protocols and assessments specific to the work that we are trying to achieve. And of course, our P4P reporting. And getting to the point where we've effectively developed over 20 protocols supported from a pathways perspective. We have a home health initiative as well. And then we have a community health assessment team that also leverages the platform and goes out into the community and understands and assesses certain needs for individuals. And so we've been able to certainly adapt the platform to meet our needs in those areas, and have done a tremendous amount of build on the front end, let's say, to be able to achieve that. So a lot of the user design experience to develop that, because originally Innovaccer was really primarily established and has more experience with their product in kind of the Medicare ACO space. And so you typically see them ingesting CCLF claims data as opposed to, more of the eligibility and MCO style files, roster files, to address a lot of the Medicaid challenges and workflows. And so, there's been, growing pains in terms of being able to adjust their analytics to support our needs, just because as you create a platform somewhat on the fly, you have to be able to make sure that the data is captured somewhere and then make sense of it. So there's been a lot of work on our end to have to do that. I would say if we're looking here on the left-hand side in the data ingestion processes, certainly being able to pull in, lab results and hospital information, and I think even some of the pharmacy data from PBM data to be able to address adherence is something that they have a lot of experience with. I think when you get to the point you start taking a look at, public health agency information, biometrics, some of the community organization data and subsets that don't really have, the ontologies, if you will, or set structure, that's where challenges come in, right? So, we're working through that. We certainly appreciate them as a vendor partner, because there's been some, there's certainly a lot of design that's had to go into our environment. Why don't we walk through the next slide here? Thank you. So this is their vision, I would say, in terms of what they're hoping to accomplish. I think eventually Innovaccer is looking to bring together more partners from an MCO perspective, certainly being able to support even employee care and clinical trials down the road. So this is not like current state by any stretch of the means, but I think that they're hoping to become a more effective unifier of data long term. And it's going to take time, essentially, but they do have some aspects of data integration that they've been successful with thus far. And I think that the environments associated with Medicare patients especially is a sweet spot for them, and Medicaid patients is something that they're still working through. Okay, we'll go to the next slide. So, this slide represents really some of the value propositions that the platform is kind of speaking to when they are looking to engage some of their partners. And I think for us, we're really leveraging them to help with some of the preventable, avoidable ED visits. Our utilization numbers certainly in the community for clients that have engaged in our either pathways programs and health homes programs has shown tremendous value for the community in that regard. I think, some of the other areas here in terms of, obviously reducing network leakage, we don't have a lot of experience with, or, some of the financials, the cost analysis type work. But in terms of the disease management, we are getting to the point where some of our partners are going to be cohorting, developing registries. All that functionality is there, and has been used pretty successfully with other ACOs and other kind of risk-based programs. Okay. Let's jump to the next two slides here. Keep going, please. Thank you. So this is really the breadth of the work that we've put together thus far in terms of the PCHI, the Institute supported pathway protocols. Specifically, a lot of the assessments that we developed for depressions and the COVID assessments, and a lot of the behavioral health assessments and screenings. There's been a lot of work and a lot of effort, and I think those workflows are very effective. And so I think one of the positives, just to be able to take away from this, is the data flow and the data capture is something that this platform does very well. There's a functionality called strategies that allows for some automation of emails and follow-ups and task assignments across teams. And so, the ability to function like a patient-centered medical home style and a team style environment, collaborate with some of your primary care provider organizations and partners, and send certain communications across into their systems and do some sophisticated alerting. That functionality is there. It's got to be built out, and there's efforts that take place there, but that functionality is certainly there. And so as we progress and bring on some of our additional partners, what we're doing as well is expanding our data platform efforts. And a lot of that has to do, again, with kind of our expanded scope to serve the community needs. This is going to accelerate the data ingestion, kind of those different community data sets that are very difficult to make sense of and bring together into a unified system. Okay. And so we're working to really complement our Innovaccer platform and use Innovaccer for really what it's intended to do, which is like care coordination and outreach effort. Okay. So, as we work through that piece, we, also recognize that Innovaser has this kind of limited data science and health economics support. So there's some functionality around risk rising of analysis or populations, some scoring specific to say, some of the PAM scoring for activation that we've brought forward as, third-party investments, and pulled those through into the system. We're also licensed for AMP Eartha from an SDOH perspective. And I wouldn't say that we've leveraged that to a great degree thus far, but certainly there are areas that we see in terms of being able to help support communication with our community referrals from that perspective. So, we're maturing our environment, just as you would expect. And, from our perspective, the platform has served certainly some of our needs, but not all, right? And I think it's a lot of that has to do with, our aggressive scope to a degree. You can jump to the next slide. So let's go through some of the evaluation, I think, and just to help with your thought process on this as well. Why don't we jump to 15? So I think when we're taking a look at vendor analysis, doing the appropriate requirements gathering is always going to be, first and foremost, right? And so when we took a look at some of the workflow requirements that we had, there weren't a lot of systems out there just in general that could meet our needs. And so when that particular evaluation took place, the innovation conversations were more adept because we thought that it would be pliable to the workflow requirements that we could build out. So when you're looking at this as from a consideration perspective, what sort of programs are you looking to institute? And how do you think the vendor matches up to adjusting to those programs? Do you need email outreach? Do you need digital engagement capabilities? Do you need some data science components that allow you to address rosters effectively and work those rosters and assign those rosters to individuals? So I think that's part of the dialogue that has to take place with any vendor selection is just making sure that you understand what your business objectives look like and match those up with your use cases. And then, what does the support model look like, of course? And so, I think the vendor has done a decent job of working with us to help establish these protocols and do this heavy build. I think over time, they've obviously have a huge growth curve as an organization. And so when that occurs, you tend to see new individuals and new faces on your support team. And so we've experienced a little bit of a struggle with some of the support as they've grown, just, from let's call it an effect of their success, right? So I think that's just a challenge we always work with from a vendor relationship perspective. Can we jump to the next slide, Divya? Thank you. So this is kind of a decent starting point. KLAS is a kind of a well-known vendor analysis for health IT system, and anybody can go in and jump in and read the comments here. They do have a great score, obviously, for this particular program. I think their metrics are very high when it comes to the functionality, certainly. So I think that there's a lot of strong functionality to be able to address both certain individuals effectively populations and population management. So, and we'll go into some more of the, quality measures and data analysis there. But yeah, I think, as you can see, I think they've been on the bottom a little bit more focused on the IDNs in larger organizations as opposed to, smaller standalone organizations. And so I think the scores are probably going to be higher if you are a larger customer of theirs, for what it's worth. Next slide, please. Okay, so in terms of platform utilization, we've been able to certainly centralize the work efforts of a lot of our care coordinators and some of the community health outreach. I think that as we go forward as well, there's some automation that's helped us, and reducing some of that double documentation. And so, for instance, working with a particular partner that allows for the care coordinator documentation to be pushed out to their medical record system, right? So that some of their physicians can see that and kind of do a little bit more whole health analysis. That is certainly something that's there and viable, and those connectors are able to be established. You have to have some of the talents, I think, on your team to be able to draw that forward. I think the vendor is only going to kind of go so far in terms of being able to activate some of that, those components. Okay. But again, as we go forward, a lot of our partners are going to be doing a little bit more of the cohort analysis, both from a condition specific perspective, and then also for HEDIS score QCM work, right? So for colon screening and mammography screening, et cetera, heart risk management. So there is some of that ability to, again, kind of create those cohorts, create those registries, and make certain adjustments to those registries as you go forward. Okay, next slide, please. And then, yeah, just some additional examples, I think, here in terms of the visuals. This is going to be an area where you're seeing a lot of the dashboarding kind of grow into your workflows. They do have these, maybe 6 or 7 dashboards for the greater analysis of the populations, both from a care management perspective or physician effectiveness perspective. We have one currently where we're trying to mature around protocol use and kind of uptake within our population. So go to the next slide, and I think we'll probably wrap with questions here. And so, again, I think this really shows some of the data analysis that we're doing in terms of the attribution, in terms of the PMPM cost analysis from a programmatic perspective. I don't have anything showing the clinical cards and the data that allows you to see immunizations and past lab results and things of that nature, but they do have a very robust, I think, human interface to be able to see that effectively, see the patient timeline, and really understand what kind of the next steps are for managing that individual. All right. So with that, I think I'll stop and we'll probably grab some questions.
All right. Thank you, Dan. And Jody, do you have any closing comments before we open it up to questions?
No, I don't think so. I mean, I would say, Dan has much more experience in terms of working with EHRs and different systems. And so my primary experience comes from Epic. And so I will say that Innovacer has been quite nimble to work with and allowing you to build out the workflows the way you need to build them out. I would say the other side of that double-edged sword is, like Dan said, you really have to have the talent on your side of the fence to be able to build those out in a way that will lend fidelity to the data. and make sure that, you know, we're not kind of looking at that garbage in, garbage out scenario. So there is strategy in terms of building those workflows out. So that is one of my primary takeaways from Innovator, is that while it does allow that flexibility and nimbleness, we also have had talent on our side of the fence, which is why we now have Dan and a couple other experts to really help us shape that front end so that our back end looks much cleaner and our data has a lot more fidelity. So that's all I would add there. And then we would love to take any questions you all have.
All right, so let's open it up for questions to either Jody or to Dan about what you just heard from Pierce County. Surely some of those slides prompted some thoughts about what this might mean for us. Somebody, I mean, I have questions, but I just want to I just want to wait and see if questions from the floor, so to speak. So anybody from then the staff at Greater Columbia would like to pose to either Jody or Dan? Carol?
Sure, I will ask Jody and to talk about, you know, how you were able to get your community members on board. You know, what did it take? This is a big endeavor. It takes a lot of collaboration, a lot of cooperation. How did you go about bringing everybody along?
You know, Carol, I think for this, the business model really lends itself to a solution, not necessarily Innovator. And I really think that, you know, there's a variety of products and they all have like the positive and negatives about them. I think really what brought people on board with us was actually the strategy of just bringing down those silos and having a solution that could potentially offer that opportunity. And so I really think that that is what garnered interest more than anything. It's that people in the community are desperate to see a whole picture and a fuller picture from whichever point of service they are, they're approaching a patient or a client. And so I think that really that is what has driven the impetus behind this. I also think that Innovator, although they're growing, I think that, you know, they're relatively in their infancy, right, as an organization. I think that they do have some solid products that really speak to people in terms of their registries. They have some other products built into their system. They have their own closed loop referral system, which mimics in many ways Unitas, but it's free. So if you're in the platform, you can use that. Like Dan was saying, that's connected and integrated with Aunt Bertha. I think they have a great telehealth option. And so I think as people have been looking at this, they're seeing, depending on the area in which they serve. So if it's an FQHC, they may be interested in some of those other products and options as well. So we have used it largely for case management, but in demos, when people have shown interest, we're showing them the whole complement of products, because really, if they're going to be looking at a platform, we want them to know everything that's available to them. So Dan, do you have anything else to add there?
No, you captured it.
Okay. Okay.
Thanks, Jody.
So this is Wes, and I I mean, this is just so incredible. It's a bit daunting. So, you know, my I guess what I'm seeing, what I'm feeling from the presentation and talking to you previously is that it seems like this system is really geared up more for health systems, hospital health systems with integrated primary care. I don't get a feeling or I don't know if I have a strong enough feeling about how it integrates with community-based organizations. And perhaps the incentive for health systems to link up with this is the potential of taking on more aggressive risk contracting models, you know, the HCP LAN levels, or stage 3, maybe even stage 4, if you're familiar with that, total cost of care, global capitation, et cetera. So Am I interpreting that right, or am I off the mark on that?
Dan will likely want to speak to this as well, but I mean, I do think that is largely true. What I will also say is, I think Innovaser in partnering with us, we're pushing them hard, right? And so I do think because they're young and they are nimble and they're willing to come to the table, we're pushing them really hard in these directions, because for us, we want to create something different. And so I think that they are young enough to join us in that, but it is a stretch for them. And so, Dan, I don't know if you would say that differently, but that's my take on it, Wes. We do want behavioral health integration. We want some of these smaller partner organizations as we look toward building out a network. Those are going to be vital components of this.
Yeah, and I'll just piggyback. I think, you know, just in general, the market has been looking for a solution to be able to address this arena successfully. And, you know, the developments to do so in health information technology follows the money. And so the contracts haven't been there in the past to be able to really incentivize a software company to make a major push in this environment. And so when you talk about, you know, the engagement aspects that are really crucial to pull together the community, you're really combining a medical record system with a health information exchange style environment. And that is very new, I think, from a IT perspective. You know, getting these data assets to come together as well as a you know, it's a challenge because, again, a lot of the identifiers of who these patients are in one system don't match up with the identifiers in another system. And so does it mean that they're the same person? Does it mean, you know, that we should trust the data? And so the fidelity of the information is also driving some of these challenges.
Thank you, Dan. Thank you, Jody. Any other questions of Innovaser and Elevate Health's experience with it? So Jody, I'll just ask you a question. You mentioned there has to be talent beyond on the other side of the fence. Can you elaborate just what that means specifically for Elevate Health with this endeavor?
I sure can, and I'm a very transparent type of individual. And so you know, when I first came to Elevate Health, we kind of came into the workflows that we had built out, Safe for Health Homes, and they were lacking a lot of compliance components. We didn't have billing integrated. And so I think in terms of looking at rebuilding those types of even the workflows, and you think of workflows very simplistically, right? It's a workflow. You're going to, you know, ask the question, you're going to document the answer, but it's really not that simple, especially for people like me who are running clinical programs. I'm a social worker. So I don't have experience in configuring workflows and making sure that we are capturing data points in a certain way because I'm not working with the data on the back end. And so really, I think that's what I mean in terms of having talent on our side. So what we endeavor to do is to bring on Dan, to bring on project managers with experience in tech land, and to make sure that while we're providing clinical content, that those configurations for those workflows are working really well in connection with the back end and those data pieces as well. So we did bring in people who can really help us ensure that those workflows are working properly as we're trying to pull data out, because that is the whole point of this, right? We want to be able to tell a story and to contribute to a larger pool of information, even with our care coordination programs. And So that's what I meant. When I came in, it was daunting because I'm like, I'm just a social worker. So, I mean, I can write down clinical questions all day, but how are we capturing that appropriately? And what does that look like in terms of discrete fields on the back end and making sure that we have the outcomes that we're trying to show? It's a bit more complicated process than somebody like me with a clinical background was able to undertake effectively and appropriately.
Okay, thank you.
This is Wes. Actually, I have another question, if I might, for both Jody and for Dan. So maybe I missed it, but I didn't see any integration with the state HIE, One Health Port. And I'm wondering if that's part of this buildup, or I believe you've mentioned previously that you're going just directly from MCO claims. So what's the story there? Are you integrating One Health Port into this system?
Dan, you want to go ahead and speak to that?
Yeah, I can speak to that. I think, you know, we took a look at One Health Port and the information that's available there. I think the options in terms of connectivity are through other, there's other avenues to do that as well, and obtain some of that information. So I think, you know, we evaluated that connection. We were seeing that we'd be much more effective in terms of bringing in some of that data through other vendors and vendor partners. So we've got Collective Medical as one of our partners that we're working with there to get data augmentation. There's other kind of social determinants of health, data enrichment partners that you know, we're evaluating and exploring. I think there's other groups like the Sequoia projects that we're looking to connect with as well, to be able to make sure that we have some of the you know, patient event information around the community.
Okay, well, thank you for that question, Wes. And I think we're going to have to wrap this up, but I'm sure you're going to be hearing Jody and Dan from Greater Columbia ACH over the next few weeks about this presentation. And anybody on the line, I'm sure if you have questions, this was quite a technical presentation that you still may be digesting. Please go ahead and get a hold of Carol and Wes and anybody else at Greater Columbia. So again, thanks for your time, Jody. Thanks for your time, Dan. And we'll just, Demi, if you could bring up the results of the survey real quickly, and we will just, can you pull those up, or is that not possible?
Patrick, actually, I have them up.
Oh, thanks, Wes. Okay.
Yeah, if Demia wants to let me.
Why don't you bring them up, Wes?
Okay, hang on just a second here. I'm going to refresh. Hopefully my system doesn't crash. Okay, so let me share my screen. Hopefully that's not too small.
Can you expand that? It is a bit small. There you go. That's better.
Okay, so thank you everybody who participated in this survey. So far, 27 individuals have responded. Thank you. As you can see here, the distribution, the histogram by county shows that Yakima had the most respondents with 9, and Benton following with 8, followed by Kittitas, Walla Walla, and the rest. Unfortunately, no one from Garfield or Asotin responded. So thank you, and other.
Okay.
So the next question, what sectors do you work in? We have public health, that is awesome to see. FQHCs, primary care, hospital, behavioral health. So community-based organizations, it's good to have those being represented here too, as potentially any CIE, at least that we go with, not going into the HIE world quite yet, but CIE, it's crucial that they be integrated into this, this as well, and a few others. Going into the next one, what do you think is the level of need for a broad community information exchange in your area? So the bottom bars represent the strongest positive response. Keep that in mind as we go through some of the later questions, but here it's pretty evident. 70% said there's a high need for a community information exchange in their particular area. And then another 18.5% said that there was a moderate need. So clearly the majority supports the idea of implementing a CIE. Going forward, so this is where we do a review of the feature build out. So rate the level of importance for each feature, which was again specified in that slide presentation that I gave. So just to show you what the legend says, orange is very important, turquoise is important, yellow is moderately, and then the top bars represent not or slightly important. So referral management, majority again here, almost 3/4 of individuals, actually more than 3/4, say that referral management is very or important. Community resource directory, this may be the strongest response among all these results. Nearly 2/3 say that having a community resource directory is very important for any potential CIE. So that's good to see. Systems integration, still a high level of importance here between those two. That looks like about 60% saying important, very important, but more individuals are sort of in the middle in terms of moderate importance of system integration into an EHR, social service, information system like HMIS, and perhaps some of the other systems that Rhonda very nicely described in her question. Social needs integration, again, important, but not vitally important in terms of its placement within a CIE. Having a personal health record, not an EHR, but a personal record within the CIE, again, along the same lines, important, but not vitally important. Privacy protection, without doubt. More than 3/4 of the respondents said that this is critical to the viability of this type of system. And then reporting and analytics, for the most part, this was indicated as being important or very important.
Great.
Going on to some of the later questions here. What other features would you like to see in a potential CIE? Stratified access based on role, being able to see what has already been done for an individual to avoid duplication. That actually could be incorporated into the patient record. Stated current information is essential in CIEs and is hard to keep 211 current. We talked about our strategies through contracting with WIN2 or WA211 and our LINs to help with that process. I don't believe a CIE is going to effectively solve this for anyone. I would agree with that as well. The community resource directory supports the CIE, but the CIE has to stand alone in terms of its robustness and integrity. Interoperability, direct-to-consumer communication, this should be as easy as possible. Integrating the education system may be helpful in terms of ACEs and resilience. That could potentially be one of the use cases that gets built into this system. System that will integrate with all the different EHRs. We had talked about integration before. We'd like to see the ACH stay out of this world. It's not really your area. We don't need another poorly executed duplication of resources and work that others already do. Interesting response, and we appreciate frank answers here. The ability to see criteria for referral acceptance that each agency has, capacity, waitlist, PAR providers, participating providers versus non-participating with health plans, service coverage areas. This is kind of another level of features within the system. Alerts. We struggle with providing easy to access alerts about potential violent behavior, special needs that also don't unfairly label patients. The more information that we can exchange, the better the health outcomes are, the final response. Any other thoughts with regards to this? It would provide quicker connections to service, and the individual will only need to share their story only once. So that's a supportive comment, none applicable. Whatever CIE is chosen, I hope that there will be continued funding and support for the CIE over time. This is really a crucial question that we're aware of as well. Financial sustainability is critical. Any CIE will require advocates and champions to bring community-based organizations on providers on board. If things get too complicated, I think it will lead to difficulties for people to navigate. We need to be thinking about a system that could be navigated for those who need it most. And then there's a listing of some vulnerable populations here, including the Hispanic population, those who may have disabilities. Appreciate the work is being done. I recommend that a statewide system is set up and not a different system by each region or by each funder. Also one platform so that we are not required to enter duplicate data into several platforms. I don't believe you have the capacity to create something that will be relevant or sustainable. This is complete duplication of resources. You should focus your efforts on supporting and improving current systems and not creating the wheel. Traditionally, resource guides have been difficult to maintain. This is really important. It would also be important to somehow make sure that all agencies can be part of the CIE for referral flow as they join the community. I look forward to having access to a CIE for my staff. I think it would be amazing if we could actually get one to work that we all use. I think we do a pretty incredible job communicating amongst agencies and KITITAS, but I take a lot of extraordinary effort when resources are stretched right now. A lot of people are falling through the cracks. High quality usable resource directory would be most enormously beneficial. And thank you for your hard work. That is the survey. Any questions?
Thank you, Wes. That I think that was very helpful. I'll just speak for myself, and I'm sure the staff at ACH, at Greater Columbia, ACH is going to be evaluating that. Those responses as we move forward over the rest of the year. So thank you all for taking the time, the 27 who did that, to provide those candid responses. That's what we like. With that, pardon me?
Sorry, this is Joyce with 211. Will that survey be sent out on an email to those that were not able to attend today? Because that was such an important survey.
I'm sure that can be done. I see Carol's head nodding, so no problem. All right, since Carol, you're on the big screen, any concluding comments from the executive director's chair?
Oh, you know, we've been talking about CIE for several years. And Wes has done a lot of work. We've read reports, we've met with vendors, but this is where it all starts, is talking to our community members, discovering what they need and what's most important to them, because in the end, you know, we rely on our community partners to be the implementers and the champions and the advocates for CIE. So Joyce, yes, we are going to be sending this out through our Leadership Council distribution list so that we can get a lot more responses and better direction on where to head. I thought it was very helpful to have the Healthcare Authority speak to us honestly and frankly about where they're at with their CIE. And clearly there are some ACHs that are ahead of the game. There's not any HCHs with as many counties as we have, however. So that's why we've kind of dipped into this very carefully. So, but more to come. This is a major scope of work for Greater Columbia during 2021.
All right. On that note, then we'd just like you to stay tuned for May, and you put that back up there, Demia. I think it's, did I see May 20th? For sure, it's the third Thursday of the month at 9 o'clock. There we go, May 20th, week before Memorial Day, more or less. And I'm sure that you'll be hearing from us shortly about the agenda. That's something we spend quite a bit of time on in advance, and takes a bit of work on the staff's part to put together I think the outstanding speakers that we typically get for these events, including today's. So with that note, thank you to all the speakers if you're still on the line. Thank you to all for attending and keeping this Leadership Council alive and vibrant. And enjoy spring. Just pursuing those things you put in the chat box. I found that good. I found that interesting. So We will see you in a month.
Thank you,
Thanks,
everyone.
everybody.
Thank you,
Take care.
everybody.
Thank you. Bye-bye.
Bye-bye.